So, hello everyone. Warm welcome on behalf of Nihon Kohden. It's my pleasure to welcome you to this session about lung recruitability. And as the main focus is the session and not my speech, I quickly want to introduce the main actors. I think everybody knows Professor Marcelo Amato. We're extremely pleased to have him as the main speaker for the audience. The gentleman next to him is Marcelo Beraldo. He is a clinical researcher from Nihon Kohden OrangeMed, our manufacturing and development site for ventilation solutions. And a special thanks also to Lerdal for helping us out with their latest mannequin technology for the lung simulator. And as you can see, we have also a pig lung over there working for us. So without further ado, I would like to hand over to the main speakers. So enjoy the program. Thanks for being here. Thank you.
Good afternoon, everyone. Thanks for coming. Our goal here today is to present some clinical tools from the NKV 550. It's an ICU ventilator, okay? And this vent has some tools that will help us at the bedside to do a lung and diaphragm protective ventilation, okay? Regarding lung protective ventilation, this ventilator has 3 clinical tools, one for lung recruitability, another one for lung recruitment, and another one for PEEP titration. And regarding diaphragm protective ventilation, now this vent has the non-invasive muscle pressure. We have the waveform in real time, and we have the monitor for muscular pressure. So basically what we have been doing with this vent is creating some clinical tools to help you guys at the bedside to do a better lung and diaphragm protective ventilation, okay? I would like to invite Professor Marcelo Amato to present something here to you guys. And then after his talk, I want to present what we have in this ventilator here. Thanks for coming. So I connect the vent to the patient. On that screen, you can see our main screen here. As you can see, on right lower corner, we have some applications, okay? I have recruitability assessment, is this application here. We go through here, and then you select the way you want to do the maneuver. You select the amount of pressure, you can select the respiratory rate, the file 2, how much pressure you want for this patient. For example, on this situation here, if I change the maximum pressure we allow, we change the maneuver a little bit. For example, if you want to do a more conservative maneuver, you can do something like this. Or if you want to do a more hard maneuver, you can do something like this, okay? And then you can set the maximum pressure, the minimum pressure, and the duration of each step of the maneuver. For example, here, 30 seconds, each step, okay? Respiratory rate of 20 breaths per minute, which means 10 breaths per each PEEP step of the maneuver, okay? And then I'm going to start here. All good? Start the maneuver. Sedated? I think he has some efforts here. No? Okay, sedate. As you can see on the top here and there the PEEP step. And on the bottom, you can see the compliance, okay? When PEEP changes, automatically the vent will change the PEEP for you. You don't need to do nothing. You just need to come in here and adjust the settings. And then now the vent increases PEEP from 5 to 10, okay?
very important to look at hemodynamics at this point. Yes, it's what we call quasi-static. And typically in the, let's say, incremental phase, compliance always drops down. It's very unusual that it goes up, only in very...
25.
This is the maximum step, right?
Yes, and now we're gonna start go down again. Yes, plus 15. Yes. If you come in here, we can check. Here, on the settings. You go all the way up, and now you're going all the way down. Okay.
You are going to understand why we do incremental and decremental. It's very essential. Because it's the only way that we have some quantitative measurement.
Okay.
Yeah, now we see something interesting because you can see that now we had a PIP level here, but look at the compliance now. It's above what we had here during the incremental phase. And this is very essential to this maneuver. We are comparing compliance at the same PIP during incremental and decremental. And this allows us to get a good, let's say, measurement of the recruitability.
In a few seconds, the ventilator want to show you if this patient is high recruitable or not recruitable. Oh, take a look. Recruitable volume for this patient, 64%, gain in compliance, 100%, which means this patient has high recruitability. Right, Marcelo?
Yeah. We did an experimental study to prove these measurements. And the idea is that first we did a CT study and then an EIT study trying to relate the amount of collapse and the change in compliance that you have with this maneuver. And then we tried to establish some boundaries to see if, let's say, the gain in compliance could be related to a certain amount of collapse reversal. So let me show you this study. It's going to take 5 minutes and we can understand how it works. This is the common way we see the recruitability. This is an animal that is highly recruitable. We are increasing PIP exactly like in this maneuver. And for instance, if we go to this other animal, he was already recruited, so there is no recruitment during these steps. So high recruitment and low recruitment. Okay, so low recruitment could be also a lobe that was completely filled with pus, and then you could not recruit like in this animal with normal lung. So we have, in many studies, for instance, this study validated in anesthesiology, we have described this Costa method that we used with EIT. And when we do the PIP titration, we can calculate the amount of collapse in different PIP steps and the amount of overdistension in blue. So collapse, overdistension, and in green you have compliance. What is special about this method? First of all is that there are some good studies showing that the crossing point decreases lung injury. So if you choose the PEEP level at this level, and this was shown now in the lab of Professor Laurent Brochard, you can maximize your lung compliance at the same time that you decrease lung injury, because you don't have much collapse and not much overdistension. And typically this coincides with 0 to 2 transpulmonary pressure. So this method has a good correlation with the proper use of an esophageal balloon. Another thing that is very good about this method is that in CT studies, we could show a good correlation between lung collapse measured by CT, quantitative CT, and the amount of collapse calculated by the Costa method. And you can see interesting things like this. A patient is supine. The crossing point is here at 11, so this patient would need an ideal PEEP of 11. But if I change position, the abdominal weight is going to increase pleural pressures, and then you need a higher PEEP. So let me just jump here. And then I would like to show you now the maneuver examined by EIT. This is exactly the same maneuver that Marcelo Beraldo presented here. The maneuver performed automatically by the ventilator. Below, you see the airway pressure tracings, and in the upper tracings, you can see the EIT tracings, so the plethysmograph, which is showing volume changes in the lung. So below you see pressure, and here volume changes. You can see that the shape is different from here. Here we see everything symmetrical because we have the same PEEP here and here. But look at the difference in terms of lung volume. When I change from this pressure or this volume to the same pressure in the decremental phase, you see this big gain in functional residual capacity or end expiratory lung volume. At the same time, you can see that there is an increase in tidal volume. And we could not see here in the ventilator because he was not showing the tidal volume, but tidal volume increased. So this means two things. You gain the recruitment because you increase lung volume for the same PEEP. So you increased your FRC. And at the same time, you increased compliance. This is why your tidal volume is higher, right? Again, an example of a patient with high recruitability. The blue line is showing some hysteresis. So the decremental phase has much higher volume than the incremental phase. And the pressures, airway pressures, are in red. They are very symmetrical, incremental and decremental. This is much more recruitable, you see? Now the asymmetry between the inflation phase and decremental phase is very large. And this is a typical patient that does not recruit. Then you do not gain lung volume during the decremental phase and neither tidal volume, so your tidal volume is the same. So then we made the rationale, is it possible that the gain in tidal volume or the gain in compliance is correlated with the amount of units that you gain? And this is exactly what we tested. Just one detail, because then you're going to understand how the maneuver works. If you have just a drop in compliance during the incremental phase and decremental phase, and there is no asymmetry, so you finish the maneuver with the same compliance, you are 100% sure that this patient is not recruitable. But if you finish the maneuver like this, you have a small drop, but then during the decremental phase, your compliance jump up to 100%, 200%. This is a signal of a high recruitability. And we tested this with EIT, again, a patient that had a drop and then a big increase in compliance. And then we measured this gain in compliance and tried to correlate with the amount of collapse reversal. Again, this is a case that there was no recruitment. Let's see what we found. We measure all the steps with EIT, so you started to increase your PEEP level, you start to have some overdistension, but then at a certain point, you recruit everything, you have only overdistension, and then you decrease your PEEP level during the decremental phase, okay? So we measure, and by using this image, you can quantify the amount of collapse and overdistension. And these are the final results. So this is collapse reversal measured by CT and EIT. So some patients had 40% reversal, more than this, 50%, which means that, let's say, half of the lung was completely collapsed and could be completely reopened. So typically this represents 1 kilogram of alveolar or of a lung mass. So you can recruit 1 kilogram of the lung. And this is obviously, this is proportional to the gain in driving pressure. So you reduce driving pressure if you compare the same step during the incremental phase and the decremental phase. So I was trying, so what is a meaningful recruitment? How we could define that this amount of recruitment is good enough for your patient? We don't have a good clue for this, but we have some indication from driving pressure, because we know that any reduction in driving pressure gives us a 4% improvement in mortality. And this is well proven from many studies. So we came to a kind of estimate that if we have a reduction of 2 or 3 centimeters of water of driving pressure, this would be clinically relevant. And then we established this threshold. 1 second. Okay. And then look at this. If your compliance gain could be increased from 20% to 100% or 160%. And this correlates with a collapse reversal up to 50%. And then whenever we have a collapse reversal more than 10%, your gain in compliance is more than 35%. And very luckily, this correlates with a reduction of 3 centimeters of water of driving pressure. So clinically, we are trying to establish this kind of threshold. A recruitment maneuver would be worth it, or I can say that this patient is highly recruitable if I can gain 3 centimeters of water of driving pressure, if I can gain 35% of compliance, or if I can reverse 10% of lung collapse. But then you need a CT or EIT. But if you don't have it, only with the ventilator, you more or less can say that every time you have a gain in compliance of 35% using this maneuver, very likely you are going to improve your driving pressure by 3 centimeters of water. And then for this particular patient, if we follow this regression line, so 100% of recruitability of gaining compliance means about 10 centimeters of water reduction in driving pressure. So this is more or less the rationale of this maneuver. So now let's keep going.
Okay, thank you. Any questions to Marcelo?
Yes, yes. So this maneuver is meant, you know, this is a recruitability maneuver. So you're trying to assess if your patient is highly recruitable. And then, okay, we already know. So he's very highly recruitable. Potentially, you can decrease his driving pressure by 10 centimeters of water if you apply the proper PEEP. Now you have to decide yourself if you want to do this, because you are going to need a recruitment maneuver and a titration of PEEP, and then you have to pay the hemodynamic price, right? But then this maneuver is just to say, oh, this patient is potentially highly recruitable or not, okay? And this is the meaning of this maneuver. And then you can choose the thresholds of pressures that you achieve, that you feel safe. For instance, in this case, maximum pressure was 40 centimeters of water.
We have one more there.
Right. So the first question, I would say just once, or if the patient is running to the second week, I would do it again to understand if this patient is still recruitable. And from CT studies, we know that recruitability is not an on-off, it's just a fading away. And many patients are still highly recruitable in the second week. So you have to test. And especially if the patient has a second hit, for instance, he has a new infection, then it's possible that you have to assess recruitability again because he can have lots of collapsed tissue. And for your question?
For your question, the second one, let me show you here how to do. Let me go to the recruitment maneuver, the second maneuver here. Let me do a very gentle recruitment maneuver here to this pig lung here. And here, this is the PEEP level at the end of the maneuver. You can set, for example, here to 15, or let me put less, 13, and then you switch from recruitment maneuver to PEEP titration at this level of PEEP. If you guys want to do a PEEP titration, let me do a very short recruitment maneuver here. The ventilator now is connected to this pig lung. I'm doing a gentle maneuver because if I put more pressure, probably have some issues here. And as you can see here, you just need to come in here, set up the settings, and then the ventilator, you do the maneuver for you. Have some leak here.
I think now many ventilators are doing automatical and programmable recruiting maneuvers. I personally like this because it makes very safe, because you can just abort and then you can pay full attention to hemodynamics. And this is extremely important. So you have to do the maneuver with your eyes on the blood pressure and cardiac rate. And ideally, if you have any technology of pulse contour, also could be very nice. Saturation is well known to be a poor signal, so don't pay attention to saturation. It's well proven that saturation can go in reverse direction during the recruitment maneuver and doesn't mean a bad thing. It's just, it could be just a mismatch of, temporary mismatch of ventilation and perfusion.
So now the vent finished the maneuver. We are at the PEEP of 13. And the vent is asking you, do you want to go to PEEP titration? Yes or no? If no, you can come in here and do end. Or if yes, you can come in here and do the PEEP titration. Okay? Automatically. The settings are here. Let me do a short one. Oops, sorry.
Yes, yes.
And then we start the PEEP titration here. A decremental PEEP titration. Do you have a question, Sharon?
When you did the recruitment maneuver and you had the asymmetric compliances, there's a moment in which you can see the compliance afterwards finally drop. Can you consider that already a PEEP titration? Don't even, yeah.
Yes, if you are in a hurry, you can use this as a PEEP titration, but it's just, let's say, a little bit sloppy one because you're jumping 5 to 5 centimeters of water. Yeah, if you want to be more precise, you do 2 by 2. Yes, yes. So it's a... Exactly, exactly. So we consider this much more as a recruitability assessment maneuver. And then if you want to do PEEP titration, we recommend that you do a more precise maneuver, 2 by 2 centimeters of water. Could be either way. Could be either way. Yeah. It depends on the personal choices. I prefer to do in volume control, but some people prefer to do in pressure control. If you do in volume control, you have a better control of
Now
CO2.
we are in volume control.
Yeah, but if you're doing pressure control, you don't have to be concerned about achieving very high airway pressures. So it depends on your priorities.
Here is pressure control, and here...
I have a question. It may sound weird, but if you perform a recruitability maneuver on a patient and you see that this patient is not recruitable and it's still hypoxemic, would you still consider to prone this patient, or would you increase the FiO2?
Very nice question. I would still consider proning because proning has a benefit of improving mechanics when the patient is recruitable. But even if the patient is not recruitable, you are going to improve PO2. You have high chances of improving PO2 because of the better match of ventilation and perfusion. So you are going to have better perfusion in the dorsal regions, even in prone. So even in prone, you keep a higher perfusion in the dorsal regions, and this tends to improve oxygenation. The chances of this improvement are not that high, but I have seen patients that are the recruitability is very low, but still they can have an increase in PO2 during prone. And then you can avoid high FiO2, which is always a good thing, because I don't believe in oxygen toxicity, but I believe in atelectasis, absorption atelectasis, which is enhanced by high FiO2.
Marcelo just showing here, after the PEEP titration, the vent showed to us that the best compliance here was with PEEP of 9. Okay, and then you can decide if you want to use 9 or 9 plus 2 or 9 minus 2, whatever.
Excuse me. Before performing the recruitment maneuver, do you check for potential of recruitment, maybe with recruitment inflation ratio, or you check recruitment in every patient?
The recruitability assessment is what we call the potential for recruitment. So it's the same thing. The recruitment to inflation ratio is just a different way of doing, but I have to tell you that the recruitment to inflation ratio is nowadays we have good evidence that is let's say, low sensitivity maneuver, okay? Because think about the following. This maneuver is just testing how much you are recruiting from 6 to 16 centimeters of water. And recruitment happens in avalanche. So, which means that you cannot, sometimes you have no recruitment up to 16, and then from 16 to 18, you have tons of recruitment. So this is why I prefer to use a maneuver that you explore the whole range of PEEP that we use clinically. So I like to go up to 24. And because it's the highest PEEP in the PEEP FiO2 table, right? So typically we like to explore higher ranges of PEEP. And the recruitment to inflation ratio goes up to 16 only.
So very unfortunately, we're running out of time. Yeah, in fairness to the others that have booked sessions, we unfortunately run out of time, and we have a bit of stuff to remove, if you can see. So I hope that most of your questions have been answered. We hope that you really found this interesting. Thank you very, very much to Professor Marcelo Amato, Marcelo Beraldo. Thanks again to the colleagues from Lehrwahl for helping us with the equipment. I take the opportunity to raise your attention to the second session that we have on Friday at, I think it was 11:45 in demo box number 5 when it's coming. Another ventilation session on Friday, 11:45 in demo box 5, and we would be more than happy to see you there again. On behalf of Nihon Kohden, thank you very much for your interest, and sorry for this abrupt end, but we got to be fair to the others as well. Thank you.
Thank you.